Sir, room is open. You can start. Sir, room is open.
Yeah, we'll start in 1 minute's time. Just 1 more minute, we'll start.
Yeah, sure.
Mansi, shall I start?
Yes, sir, you can start.
Okay. So, good evening to all of you. I think this is the 72nd session of the challenging case series. In today's session, the first 15 to 20 minutes, I'll be talking about nodopathis and paranodopathis, about which people wanted to know about it in the last class. So I'll first deal with that and then go to the two very interesting cases. So I will start my share screening. Is my screen seen?
Yes, it's visible.
Okay. So what is nodopathies and paranodopathies? Mainly, I'll be stressing on the electrophysiological parameters to diagnose these conditions. Before that, it is better to know something about the anatomy of the nodopathies and paranodal regions of the axon, so that we'll get a better understanding of the pathophysiology as well. Now, the anatomy. Let's come to the anatomy of the node. The myelinated fibers are organized into distinct domains, as you all know: the node, paranode, the extraparanode, and internode. The node, which is about 1 micrometer in length, the myelin is interrupted and the axonema is in direct contact with the extracellular fluid, though still covered by the Schwann cell microvilli. And this is the node part of the this region. At the paranode, the uncompacted myelin, the myelin here is not in a compact form, but in uncompact form. And they are tightly attached to the axonema, as you can see there. It's a paranode. At the internode, which is about 1 to 2 millimeter in length, axons are surrounded by compact myelin. That is the paranode and the internode. Now, the node has got high density of voltage-gated sodium channels, about 1000 to 2000 per cubic micrometer square, and slow potassium channels. This is important because it is the where in myelinated myelinated axons, it is in this junction where the impulses jump from one node to another node. The juxtaparanode contains high density of voltage-gated fast potassium channels. Which you can see, the density of the sodium channel is relatively low in the internode, which is not sufficient to sustain the propagation action potential. That is why in myelinated neurons, the conduction is very fast because it jumps from one node to another. There are also two other important things which one should know. The sodium-potassium pump restores a transmembrane gradient for the sodium potassium, as you all know. It is electrogenic and contributes to make the membrane potential more negative because at each cycle it expels 3 sodium ions for every 2 potassium ions put into the axon. So during depolarization, as you all know, sodium enters and potassium comes out. And this has to be reversed by the sodium-potassium pump to maintain the inner negative polarity. The sodium and calcium exchanger is another mechanism we should know, which extrudes the calcium ion from the exoplasm in exchange of sodium, maintaining the calcium homeostasis. When the sodium gradient across the membrane is reversed, the exchanger can run in the reverse mode, leading to increased levels of industrial calcium. You may be asking why I'm talking about this for our patient, because this is the reason responsible for river axonal degeneration in persistent depolarization. The calcium exchanger tried to push out the sodium from inside, but in turn the calcium gets into the axon, causing the damage. Now let us see the organization, molecular organization, the nodal region. The nodal sodium channels, which is colored green, are anchored to the spectrin, which is given in the blue, of the axonal skeleton through anchorin G. This is one protein by which a sodium channel is anchored to the actin from the spectrum. So they are anchored to the gliomedin. This sodium channel is also anchored to the gliomedin or the Schwann cell microvilli by neurophysin 186. These proteins are important because there's so many types of CADPs are there depending upon the antibody to which this protein in which the antibodies are active. The clinical picture will differ. That is the neurophysin 118, which connects the sodium channel to the gliomedin. And let's see the paranode now. Here there's two important proteins of the conductin and Casper, which is given as the orange and the blue. This axonal conductin associate protein is Casper, and the conductin are tightly connected to the neurophysin 155 for the paranodal myelin region. This complex forms septate-like junctions which separate the nodal sodium channels clusters in the juxtanodal potassium channels. Now come to the juxtaparanode, contains large amount of potassium channels. These potassium channels are anchored by two proteins, Casper2 and the TAG1. TAG1 is always the transient axonal glycoprotein. So let us see what happens when there is consequence of nodal affection. There are two things which can happen. It can cause a conduction block and can cause axonal degeneration. Let us see how this is produced. Let us first look at the pathophysiology of the conduction block due to a problem in the nodal region. Now, what happens is the detachment of the terminal myelin loops here, as you can see here, detached, causes current leakage, as shown by the arrow here, and dissipates the driving current. So, what happens? Consequently, the depolarization may not be sufficient to activate the required number of sodium channels, and the conduction current is not generated, producing a conduction block in nodal. The other mechanism is that there's a direct or straightaway disruption of dysfunctional sodium channel, which is disordered here, which impairs the generation of action current. So by these two mechanisms, they can be conduction block due to a nodal. And this is the pathophysiology of axonal degeneration, which also can occur due to nodal infection. This is because of the malfunctioning of the sodium-potassium pump. So what happened is told earlier, because of the failure of the pump, the sodium is accumulated inside the axon, causing further depolarization. If the process continues, sodium accumulate reverses the axonal sodium-calcium channel exchanger. So what will happen, this exchanger will try to push out the sodium from the axon to the extracellular fluid. In that bargain, the calcium enters the axon, as you can hear. The calcium ions will stimulate the calpain, causing proteolytic cleavage of the neurofilaments, mitochondrial damage, and finally Müllerian degeneration. So this is how the nodal pathologies or paranodal pathologies can result in both conduction block and axonal degeneration. Most of these nodopathies and paranodopathies are due to the antibodies which bind to these gangliosides in the axon. Now, how does this produce? This is antibody which activate the complement. The complement will, the terminal complement of the will form the membrane attack complex or in the axonal membrane. So then what happens? Calcium enters to the pores and accumulates in the exoplasma, and activates the calcium-dependent calpain as told before, causing further damage to the neurofilaments and mitochondria, causing axonal degeneration. Now coming to the electrophysiological features, this is the main part of my talk now. Traditionally, as you all know, GBS has been classified as demyelinating or axonal, mostly on the basis of electrophysiological studies. The conduction block and conduction velocity slowing or the distal latency prolongation were taken to indicate demyelination. And axonal degeneration is characterized by reduced CMAP with CMAP amplitude with associated poor prognosis, which all know about these guys. Now, this view has been revised in the light of new electrophysiological data that demonstrate reversible conduction failure of motor nerves, which can rapidly recover in many cases axonal GBS. So we now know that even axonal GBS can produce conduction block, just like a demyelinating disease. This reversible conduction block, sometimes called the axonal conduction block, is characterized by reversible conduction slowing or block, mimicking demyelination, but without temporal dispersion. So it can result from disorders that disrupt the nodal axonema, that is nodo or paranodopathies, and it has been suggested to be the neurophysiological correlate of antibody-mediated attack on the node and paranode. So just these are the cartoons which show the normal conduction, which is accumulating positive charge at the node, causes depolarization, and the flux of sodium inside the positive charge will activate the next node and producing a propagation action potential in a fast manner. When there is a demyelination, what happens? The demyelination, that this is denuded, the axon is denuded, but axon is intact, leads to disruption of the water-irrigated sodium channel and the current leakage, the current escape from the axon outward because it is not insulated. So whatever leaks out and resulting in conduction slowing and block, that is why demyelineuropathies produce conduction slowing, conduction block. In axon degeneration, what happens is that the rest of the axon gets degenerated. So no longer the axon is just not able to conduct it now. In nodopathies and paranodopathies, as I was told before, the antibody binding to the node results in two ways. One, it results in complement activation, MAP or deposition, as you can see here, causing nodal dysfunction. Or the antibody can act directly without complement, directly bind to the paranode and also produce a nodal dysfunction. This leads to what? The conduction block as well as the conduction block and the nodal region. It can result in many pathologies such as skin tatting. So the conduction block would represent either node paranodopathy with reversible conduction block or demyelination. This can putting the conduction block can occur demyelinating disease as well as in node and paranodopathies. Conduction block can be demonstrated electrophysiologically. Either affected nerve can be stimulated both proximally and distally with respect to the site of injury. Now, these few slides are mainly meant for the junior members of the junior students. Is a basic concept of the electrophysiology abnormality in demyelination, axonal loss. This is just to recapitulate. If you get, what do you find in NCV in focal demyelination? The key fact is that the myelin degradation do not progress distally at the site of the site of injury. See, for example, in this picture, this is the area of the myelin degradation. And even if after 1 week or 2 weeks, that demyelinating lesion remains there, it does not progress distally. It will not cause further damage to the axon distally. So what will result will be a slow nerve conduction, that is prolonged distal latency and slowed conduction velocity. And if severe enough, conduction failure, conduction block occurs. Let us see, the one point remember is that this if you get it stimulate the distally like this, you get a CMAP amplitude, the stimulation is normal. If you stimulate proximally, what happens? These two nerve fibers are not transmitting impulse because it's blocked there. You get a decreased amplitude and proximal stimulation. And that is the classical conduction block. But for that, mind you, stimulation should be distal to the block 1 and proximal to the block. Then only you get a classical physiological feature of a conduction block. So the changes seen depend on the site and extent of demyelination. Remember that the amplitude discrepancy is not noted if the block is either proximal or distal to the electrode. If the block is distal to your stimulating electrode, then both amplitudes will be low. The block is proximal to the both electrodes, both amplitude will be normal, mimicking a normal conduction. So for example, here is the normal axon by 6 axons supplying the muscle. If there is a lesion here proximally, and there's a proximal lesion here, if you stimulate, there's a distal stimulation, you get a normal amplitude. If you get a proximal stimulation here, again you get a normal amplitude. You get a normal conduction. If you see the lesion is distally, here as is shown here, and you stimulate that lesion, if you stimulate distally at distal point, this point, this proximal to the distal block, you get a low amplitude potential. If you give a proximal stimulation also, you get a low amplitude potential. So essentially what you are going to get is a low amplitude potential, which can be confused with an axonal degeneration. So this point has to be kept in mind. That means low amplitude potential can also occur demyelination distally. This is again the same thing which I have shown here. If the block is proximal, you get a normal amplitude. Will only if the block is between the two, you get the classical conduction block parameters. With the distal, you got only low amplitude potential. Now, that's in demyelination, what happens is usually there's a desynchronized slowing. The slowing is not uniform. Various fibers transmit impulses at different speed. So what happened means that, see here, these two fibers are fully myelinated. This is a little more demyelinated. This is less demyelinated. So what you can, the impulses arrive at the muscle at different times. So you get a dispersed potential. But if you get dispersed potential, the area will be normal. Only thing is amplitude become low, the complex become wide and serrated, but the area will be normal. Now, remember that to get conduction velocity slowing, all fibers has to be affected. If lower fibers are spared, you get normal velocity. Because the remaining 1 or 2 fibers will conduct normally. You get normal velocity. I think I will skip this part. Now coming to the NCS and axonal loss, what happens is axon is here is interrupted, the distal part will degenerate. So whether you stimulate the evoke proximally or distally, you are going to get a low amplitude. So the evoke response are either inelicitable or uniformly low in amplitude. This is seen in lesions of 7 to 10 days after the lesion. And the responsible lesion can be located anywhere along the axon. It may be from anterior horn cell down to the distal part. Wherever it is, you get low amplitude, unlike demyelination, where you can pinpoint the site of lesion block, site of demyelination, by simulating proximal and distal to the site of block. So wherever it is, you going to get a low amplitude. Now the patterns is you can see here is that if you can simulate here, you get a low amplitude. Proximally also you get a low amplitude wherever you simulate it. Now coming to the nodopathies, what are the electrophysical parameters? A man was initially characterized by simple axonal degeneration, and his electrodiagnosis based on the reduced CMAP amplitude and absence of demyelinating features. That is how you diagnose axon among a variety of the GPS. However, patients with anti-GM1 antibodies can show conduction block or slowing that promptly resolve without development of excessive temporal dispersion and of the CMAPs. To have temporal dispersion, that's a key factor. You should have demyelination, patchy demyelination. But the nodopathies will not produce a temporal dispersion. There's a block occurring at them. And owing to the rapid recovery and lack of slow components characteristic of demyelination, this conduction block was thought to be caused by impaired conduction of the nodes of ganglia, possibly due to the temporary loss of sodium channel function. And this has been called the reversible conduction failure or conduction or axonal conduction block, distinguished from the demyelinating conduction block. The dysfunction or disruption at the node of Ranvier can result in pathophysiological continuum from a transitory nerve conduction failure to axonal degeneration. How this is produced, which already told in the initial platform. And the recovery in patients with AMAN may be either very rapid and complete or prolonged with poor outcome, according to whether it is a pure reversible conduction failure or axonal degeneration. So, for example, in this patient, he's got a normal myelinated axon with a proximal stimulation normal amplitude. This is the site of your nodopathy. So what you're going to get is that you're going to get classical conduction block pattern, just like a demyelinating neuropathy, demyelinating GBS. One follow-up, what happens is that if that block is removed, this becomes reversed. This is reversible conduction block. If you find a distal block here, distal nodopathy affecting distal stimulation, what you get is a low amplitude potential. If that block is removed by treatment or otherwise, amplitude becomes normal. So such a condition reverses quickly back to the normal amplitude. So unless you do the repeat conduction, you will miss this thing. So in the initial value itself, you might say QA diagnose axonal AMAN, axonal variety of axonal degeneration. Unless you do the repeat conduction and find that the amplitude has come back, then you would know that the initial amplitude might have been due to the distal conduction block. What happens in the case, this other consequence of nodopathy is axonal degeneration. This is a conduction block, which is classically, which already shown here. One follow-up on this, what will happen, the distal axon will degenerate, depending upon the severity of the nodal involvement. So you are going to get a low amplitude potentially later on. And this variety of nodopathy has got a poor prognosis because what is resulted in is axonal degeneration. I think I'll skip the subtypes and all. These are gangliocytes. I think we'll skip in the interest of time. So just to come to last 3 slides to complete the electrophysiology of inflammatory neuropathies. The AADP is electrophysiologically characterized by nerve conduction slowing, conduction block, and excessive temporal dispersion. Motor conduction slowing usually progresses after 6 to 10 weeks, and the resolution of conduction block is also temporal dispersion CMAP due to demyelination, eliminating slow conducting components. So this is a pattern. This is classically AADP. Initially, you get a conduction block maybe there. Then subsequent recovery, you get a dispersed potential, and then ultimately it recovers. In AMAN, 3 patterns are there: maybe simple axonal degeneration, reversible conduction block, or absent FAO pneumatic. I think I will skip these things. This is what is happening in the pathophysiology, the reversible conduction block. The nodal region is initially the antibodies are disrupted. When the river comes back, the initial conduction block becomes normal. If there is a axonal degeneration, this got totally disrupted. So you're going to get persistent low amplitude potential follow-up. So this is a summary of the electrophysical findings in all the 3. This is the AADP conduction block. See what happened. There is initial conduction block. The second one is a proximal stimulation. Then on follow-up, what happened? Then after 1 month or so, the amplitude becomes low and becomes dispersed, and the conduction velocity is prolonged. And they're going to have a temporal dispersion as well. In the case of amine with reversible conduction block, this is initially conduction block, and it reverses and come back to normal without any temporal dispersion in the case of a amine with conduction block. If the block is distally, the distal conduction block initially in low amplitude potential mimicking an axonal degeneration, but on follow-up you find that the amplitude picks up quickly and there is no rapid recovery. This is what is happening in axonal type. The amplitude is low and follow-up also continues to be low. But there is no temporal dispersion. So temporal dispersion and the conduction velocity slowing is characteristically seen in the AD, not in order for this. I think I'll skip the. Now, why it is important to know about order for this is that recently so many other antibody-mediated diseases are described. Some of the clinical picture is different and the treatment is also different. For example, in that variety due to neuroplastic 150, there is a good response to rituximab, but not to IVH. IVH is not the treatment of choice. Similarly, in contacting one related AADP and CADP, IVH will be poorly responsive. That is why many of the AADP which you see, sometimes they respond very well to IVH, sometimes do not. This will come in a big way in subsequent years to find out the antibody and the resistance depend upon the type of antibody causing your AADP or CADP. So that's about the electrophysiology of the entire order. Any doubts?
In what should be
Your voice is breaking, Joy.
in what time should we repeat the nerve conduction study?
Yeah,
In
that's a very good question. In usually 2 to 3 weeks, these studies have shown that 2 to 3 weeks, sometimes up to 2 to 3 months. That is a time period. So let's say we do not know. It should be guided by the clinical response. The patient started improving, then you can do it earlier.
Sir, I have a question.
Yeah, please.
Sir, is there any lab which delineates the detection of this neurofilament 155 contacted one and all? Because if we know the antibody, that specificity, then it would have been better whether to give the IVIG and prognosticate.
Only what we can do at the moment is cascade to antibody can be done. Other antibodies, I don't know to where India it is done or not. It will come this order. So I got some talk from North India people giving about this, detecting these antibodies. I don't know much about where it is done.
Okay, sir. Thank you.
Sir, I had a doubt regarding this sural sparing in GBS, sir. Actually, what is the exact cause or pathophysiology for that?
Now, what they postulate is that among the in the case of ulnar, median, and sural, the myelinated fibers, these two, sural is thinly myelinated compared to that of the median, ulnar is thinly myelinated compared to that of the sural. That is why they are getting affected early in the case of GBS. That is one postulate they suggest.
Okay, sir.
So is it the same reason why we say in diabetes if we get the SNAP absent in a upper limb like median or ulnar, it is more significant along with the other GBS demyelinating features.
There is also another explanation which I read somewhere. What happened in sural stimulation? You pick up the electrode, the sural potential from the malleoli, behind the lateral malleoli. So, but distal to that, lot of axon, nerve is left behind. So if there is a demyelation distal to the malleoli, you will miss you get a normal conduction. On the other hand, in the ulnar and median, you are picking from the distally, the digit, and stimulating the wrist. And that is the most point. But in sural stimulation, we are not picking up from the digit. We are picking from behind the malleoli. You understand the point? So unless the lesion is proximal, you can miss that also.
Yes.
Okay, shall I go to the case?
Yes, sir.
Now, this is a very interesting case. In fact, I referred my guru only, Professor Anarashan sir. Now, this you have to keenly work. This is a tough case. You have to keenly concentrate on the case history as well as the findings. This patient was seen in 2020th March 2022. Which I mean, what I means that seen by me. The history, in fact, dates back to 5 years back. History of episodes of convergent spasm, that's what the eyes will converge. In which the patient's both eyes will converge, lasting for 30 minutes to 1 hour for the last 5 years. And it goes back again. And the patient underwent a skin surgery on the right eye in 2008. In January 2020, the patient developed sudden onset of headache. This history is not corroborated by any other eyewitness, only he himself is giving the history. Patient himself is a medical student. Sudden onset of headache followed by loss of consciousness and recurrent GTC seizures. It was admitted and improved and put on anticonvulsants. Since that incident, since that episode of GTC, so-called GTC seizure, he was noticed a persistent adaptive position of his left eye. Since then, his left eye remains adaptive. That is from 2020, that's 2 years now. 6 months later, since there was no improvement with allopathic treatment for his adaptive position, he went for Ayurvedic treatment, and the deviation of the left eye improved normalcy and remained in the same like that till December 2020. From August 2020, patient used to have transient weakness of the left upper leg in the form of big objects with the left hand. It lasted for 6 months. 2 months back, patient noticed photophobia and was detected to have dilated pupil on the right side. And this time, patient also noticed to have transient deviation of the mouth in the left and difficulty in closing the right eye, which also lasted for the next 2 days. In March 7, 2022, patient underwent Botox injection of the left medial rectus, which did not lead to the position of the left eye. So this is the story. It's a very, very long story. Now, you want the history once again to be, you want to hear the history once again?
Yes, sir.
Yeah, okay. So this patient is a medical student, 21 and non-medical student. History of episodes of convergent spasm lasting for minutes to 30 minutes, 1 hour for the last 5 years. Underwent skin surgery. In January 2022, patient developed sudden onset of headache, followed by loss of consciousness and recurrent seizures, and was admitted and improved and was put on anticonvulsants. Since that time, he said his eyes is remaining active. 6 months later, since there was no improvement, he went for Ayurvedic treatment, and the deviation of the left eye improved normalcy, but remained the same like that for December 2020. From August 2020, as prior to that, patient used to have transient weakness in the form of big objects with the left hand, which again subsided in 6 months' time. 2 months back, patient noticed photophobia and was detected to have dilated pupil on the right side. At this time, patient also noticed a transient deviation of the mouth to the left without any difficulty in closing the right eye, which lasted for 2 days. In March, last month, March 7th, patient underwent Botox injection, which according to him did not produce any improvement. So I think from the history, difficult to connect everything together. So let us come back to the examination and then take the 11 points in the history. He said he cannot see anything with the left eye. He said he cannot see.
There were doubts, sir.
Yeah. Please. Yeah. Joy, tell me, Joy.
He had his adduction improved with the Ayurvedic treatment in December 2020. After that, again, the adduction came back of the left hand.
Yeah, correct. That's what I said. It improved, then again came back to the adducted position. Since then, remaining like that for the last 1 year.
Yeah. Okay, sir.
Now, examining the vision, is it able to see? Is it able to see the light? The pupil is reacting normally.
Beautiful reaction.
On the right eye, pupil is dilated, not
When it
reacting.
looks straight, Looks straight,
There is no RAPD on the left eye. It's no RAPD. Checking the field. Left eye, there is no field cannot be checked because it cannot see anything at all. On the right eye, there's got a superior auditory hemianopia. Lower part is able to say, upper part is not saying. Now is able to see. Yes, now is able to see. From below, is able to see normally.
In
the ocular movements, right abduction is normal. Abduction normal. Left eye, there is no abduction at all. Looking up, the both eyes are not going up. Downward movement is okay.
angle,
Up and out to the right side, up and out to the left side. There is no facial orbicularis of play normal. Touch is normal. Lower facial muscles movement is normal. Bulky movement normal. Tongue movement normal. This senses impaired pain on the left side of the body. It's sharp on the right side, dull on the left side. No, your telling is correct. Yeah.
Uniformly. Sharpness, sharp arm.
I'll tell you when it becomes more sharp.
No.
Then it becomes more sharp.
No. No.
Coronary reflex is normal.
Yes, sir.
Hearing is normal.
Yes, sir.
Motor fluid is normal. Motor power normal. No fibrinosis incoordination. The reflexes are all normal. The reflex was intact. Reflexes are all 1 plus. When the plantar was down flex on the left side, it was up 3. The sensation is normal throughout.
ഇല്ല സർ. ഒന്ന് 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 ഒന്ന്.
The pain is cystic.
വേദനയും
That's common roughly.
ചെറിയ വ്യത്യാസം വിട്ടേക്ക്.
ആ അതെ ആ സർ.
സെയിം
യെസ്
ഇതും ഇതും
സെയിം സർ.
ഇത് രണ്ടും
അല്ല
ഏ
ലെഫ്റ്റ് സൈഡിൽ കുറച്ച്
It's decreased on the left side.
ലെഫ്റ്റ്
Left is decreased.
കുറവാണ്.
കുറവാണ്. തരിപ്പുണ്ട്.
ഏ
ഇവിടെ തരിക്കുന്നു.
ഇതുപോലത്തെ ഫീലിംഗ് അല്ല.
അല്ല.
ഡിസ്റ്റർബ് ഒരു
അതെ സർ.
ചേഞ്ച് ഇൻ ദ സെൻസേഷൻ. ഇതും ഇതും തമ്മിലോ
ചെറിയൊരു
ഒരു
ഇത്
വ്യത്യാസം. ഇതുപോലെ അല്ല ഇവിടെ.
അല്ല സർ.
ഞാൻ
As you level, then it becomes sharp.
ഷാർപ്പ് ഷാർപ്പ്
ഇതെല്ലാം ഒരേപോലെ.
ഒരേപോലെ തന്നെ
ഇവിടെയാണ് ഒരു വ്യത്യാസം.
വ്യത്യാസം.
That's the level is telling when they say it becomes sharp at that level. Vibration sense is normal throughout.
ഇപ്പോഴോ
യെസ് സർ.
ഇപ്പോഴേ
യെസ്
ഇപ്പോഴേ
യെസ്
ഇപ്പോഴോ
യെസ് സർ.
ഇപ്പോഴേ
യെസ്.
ഇനി ഞാൻ ഈ വിരല്
അവിടെ താഴെ
ഇപ്പോഴേ
താഴെ
ഇപ്പോഴേ
മുകളിൽ
ഇപ്പോഴേ
മുകളിൽ
Is it happening?
ഇപ്പോഴോ
താഴെ
ഇപ്പോഴേ
സ്ട്രൈറ്റ്
ഇപ്പോഴേ
മുകളിൽ
ഇപ്പോഴേ
താഴെ
ഇപ്പോഴോ
താഴെ
ഇപ്പോഴോ
താഴെ
ഇപ്പോഴേ
സ്ട്രൈറ്റ്
ഇപ്പോഴേ
മുകളിൽ
ഇപ്പോഴേ
താഴെ
Is it happening?
ഇപ്പോഴേ
താഴെ
ഇപ്പോഴേ
സ്ട്രൈറ്റ്
ഇപ്പോഴേ
മുകളിൽ.
There is no Hilshin test positivity. It is normal.
അതേപോലെ ഈ കാല് ചെയ്യണം. ഇവിടെ മുട്ടിക്കണം. താഴോട്ട് കൊണ്ടുവന്ന് താഴെ മുട്ടിക്കണം. അതിനും മുട്ടിക്ക് ഇവിടെ ചെയ്ത് ആ
Okay. So let's rhombus is negative.
ശരി. ഇനി സ്പീഡ് നടന്നു തിരിച്ചാണ്.
It is also normal.
അവിടെ പോയിട്ട് ഞാൻ നടക്കുമ്പോൾ
And walking is also normal.
ഇതേപോലത്തെ
So that's the story of the patient. Then I will recheck some other findings on film
അടച്ചേ തുറന്നേ. ഓക്കെ. മോനെ ഈ കണ്ണടച്ചിട്ട് ഇങ്ങോട്ട് നോക്കാം.
You wanted to check the action movement. There is also
താഴെ മുകളിൽ മുകളിലോട്ട് 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 ട്രൈ ചെയ്ത് ഇങ്ങോട്ട് തള്ളിക്ക് ഇങ്ങോട്ടേക്ക് താഴെ മുകളിൽ മുകളിലോട്ട് മുകളിലോട്ട്
This is what I already shown.
എൻ്റെ വിരലില്ലേ വേറെ
The ocular cephalic, that also that no change.
ക്യുക്കായിട്ട് നോക്കണം. എൻ്റെ വിരലിൽ തന്നെ നോക്കിക്കാം.
So summarizing the finding, is conditional activity normal on the right side, no perception of light on the left side. Real upper altitude hemianopy on the right eye, under normal bilaterally, pupil right dilated, not reacting to light, left small but reacting well to light, no RAPD on the left eye. Extraocular movements, left eye in the fully adducted position, abduction, adduction, normal on the right eye. Position elevation of both eyes, downward movements normal. Fifth nerve, decreased pain in V1 to V3 vestibular on the left side. Corneal reflex normal bilaterally, rest of the cranials are normal. Motor tone power normal both upper and lower limb. PTR normal in the upper and lower limb. Abdominal reflex normal in full quadrants and left upgoing, right flexor. Sensory impaired pain on the left side of the trunk and lower limb of D6. Posterior sensation normal, stance and viewpoint. So this is the finding.
So what about fundus, sir?
Reacting to ear.
Fundus is normal. Joey, what did he say? What did he ask?
Are the pupils reacting to the same conversion?
Left pupil is reacting. Pupil is reacting light on the left side. No reaction.
Is the
right pupil is dilated and
the right pupil reacting to convergence?
No reaction.
To accommodation.
No reaction at all.
Even to accommodation.
No reaction. No accommodation reactions on the right side. The cell is already remaining converged.
So the left eye visual perception loss could be either a retinal disease or posterior to the because the whole vision is affected with preservation of the reflex, that is light reflex. It could be either a retinal involvement or something like Leber's optic neuropathy, which can have the preservation of light reflex.
But okay, that's a possibility which you can consider because everything is normal on the left side. Okay, but what about the right side? Right side, which could be
right side could be again a retinal disease or optic nerve disease, which produces a superior quadrantenopia.
Okay, and nothing in the fundus. Okay, there's a technical possibility when you get normal reflex of the eye and with the total loss of vision. Actually, you should think of a lesion behind, no? Right?
If it's a behind lesion, you should have a bilateral lesion.
Correct, bilateral lesion. So is it possible that the left eye is adducted totally so that you can't check his nasal field?
Yes, it could be a possibility.
Yeah, there's suppose you've got a complete eponymous myelopia and the left eye is adducted so that you can't check his nasal field. It has gone inside.
But then it should have reacted to light. If it's just if the nasal field is preserved, it should have it's reacting to light. It's reacting
Right.
to light.
Yeah, it is reacting to light.
So if it is
Superior
reacting,
quadrant on the other.
Yeah.
is not having any light perception in the left eye, no. So with torch also, if he has nasal field, he had to tell some field. He has to tell that some light is visible.
Even yeah, that's possible. So if there is total loss of reaction, that means that lesion is in the reflex pathway should be intact. If you say optic tract lesion, again, that possibility is there. Light is falling only on the temporal field. Even the people will not react.
Is there any carotid bruit in this patient, sir?
No, I did not check that particular point. Why carotid bruit?
The patient has left-sided human symptoms, and right-sided mid-recess of the pupil. A carotid artery dissection with the retinal, ocular emboli can have a vascular involvement of the right eye and can explain the mid-recess on the right side and cause the human lesions on the left side, sir.
Now here the right eye is an efferent pupillary deficit, not afferent deficit. The visual acuity is also normal on the right side. Left side is the one is totally not seen. And what you get on the right side is superior quadrant myopia. If you get superior quadrant altitude, not quadrant myopia, altitude hemianopia. It has to be occur should be the inferior part of the half of the retina has to be affected. Inferior half of the optic disc has to be affected as in AON, or it should be the inferior part of the optic radiation or the inferior bank of the conference optic has to be affected bilaterally. Generally, you can have that possibility.
He has unilateral altitudinal or bilateral, sir?
Unilateral?
Altitudinal defect or bilateral, sir?
Left side is totally blind. So
One eye is not.
Okay, sir.
Yeah, left eye is not all seeing. So what you could check was on the right side.
Okay, sir. Okay, sir.
Totally confusing picture, no?
Left side is totally blind. So that means it is a precasmal, like it has to be,
Yeah.
cannot be a optic tract lesion. It has to be in a precasmal lesion.
Precasmal lesion. That should be the ideal thing. That's you have to keep that person.
So there is multiple parts of neuraxis.
Okay.
Like if it is so it's a precasmal lesion on the left side. It could be a retrobulbar.
If it is an optic nerve involvement producing total loss of vision,
Yes, sir.
you should get definitely an RAPD on that side.
But on the right side, sir, it's a right side is an efferent defect. Right is not. If the field defect is being set apart, it might be because the eye is adducted on the left side. So if that is being separated, there is actually no pathology on the right side. Right side is what we are seeing is an efferent defect.
Visual pathway on the right side is altitudinal hemianopia. That's what we got.
And he had a past history of some facial deviation towards the left side, which is not the facial nerve kind of.
Yeah, right. That improved also. Okay, let us see that. So the visual part is confusing. Okay, let us come to the what is causing selected position of the left eye. And it's also restricted.
Sir, the surgery, he underwent surgery on the left side.
Right side, on the right side.
Okay, sir. So the movements are all preserved on the right side, despite him undergoing a squint surgery, sir. So he has now compensated for that. The muscles have actually relaxed now. Now coming back to the history, he has left side complete loss of vision with a preserved pupillary reflexes, sir. So there is direct and consensual light reflexes present on the left side. So it is a posterior visual pathway defect, sir.
Exactly. That's what you're thinking.
And he has a visual only seeing eyes on the right side. He has an inferior altitudinal defect. Still, we can consider possibility of a posterior visual pathway. And since the patient has UMN signs also on the left side, we can still consider a possibility of a right-sided lesion because he has UMN signs on the left side. And there is only an efferent defect in the pupillary pathways on the right side, sir.
Your point is taken, but the point is that suppose you imagine like that, you can only think, how can it produce a total loss of vision of the left eye by a cortical retrogeniculate lesion? Only unilaterally. Theoretically, you can say that patients got total hemianopia, the adducted position, you cannot say that thing. Okay, that can explain that total loss. And the right side has got another, the optic radiation is affected on bilaterally on both sides, or optic tract bilaterally on both sides. That's a possibility you can keep. But this is not very, very unusual localization. Okay, let us come back to the, so we'll keep it at that. What is causing this adducted position of the left eye again? It may indicate that it's got probably a lateral rectus is weak. Okay, the right is, the middle rectus is overacting and producing adducted position, or the middle rectus is overacting by some other, due to the contracture or by some overaction of the middle rectus. That's another possibility. Agreed? Right. So if at all, what do you suspect? If you want to think of a lesion, where would you think the lesion will be? It's got left panathalamic tract on the left side, left panel is ongoing, and right pupil is dilate, not reacting, front pupil involvement. What do you think of a mid-brain lesion? Mid-brain or upper brain stem lesion? Make it third and sixth.
Brain or bones.
Sixth on the left side, and then left in plantar and panathalamic on the left side. It's tract symptoms. And pyramidal plus panathalamic. Why the visual path you can't explain that thing? For that, the lesion must have extended up to the optic tract or optic chiasm. Sorry, not optic chiasm, optic tract with optic radiation in a patchy manner, which again difficult to believe from his findings. But still, that's only way to explain. Okay.
And he had one seizure also.
Pardon?
One seizure.
But that seizure part is doubtful, because he said he was alone in the room, and the roommates did not do anything for that. That seems very illogical. I say if somebody has a victimization, actually the roommates will take him to the hospital. He said they kept it like that till morning, next day morning. That's what history is telling. So whether he had seizure or not, we are very sure.
There's a history of episodic convergence spasm also localized to the upper brainstem.
Yeah, could be. Yeah, correct. Dorsal midbrain, yeah. Something like a convergent spasm. That's what he's telling. All what he's telling.
On which side surgery was done, sir, for the eye?
Right side, from the street side. So probably we went to the ophthalmologist because of the thought concomitant strabismus. Must have tried to correct the eye on the right side. Okay, now let us see what investigation you want. Let us see the investigations. These are structures affected.
Now, what about other facial sensory impairment versus sight?
That is on the left side.
Pons, sir.
That you have to tell me where is
Left pons.
Okay, left pons affecting the left fifth nerve, no?
Yeah. Corneal also is affected there.
The corneal is not affected. Corneal influence is normal on the left side. That means that takes the right ascending into thalamic tract.
Yeah.
There's another point favoring a right-sided lesion.
Right side midbrain lesion. And what about sensory impairment up to the D6 level?
Yeah.
That can happen.
That is there. That can also be explained by right-sided lesion.
Midbrain lesion.
Okay, these are the doubts we had. Is left optic nerve or patchy bilateral optic tract involvement. These are the possibility we have to keep in mind. But optic nerve, obviously, even the light triple RAPD is also lost. It's become very low. Left sixth nerve palsy causing action. Right third nerve palsy because of different pupil deficit. And upward gaze loss of movement maybe due to upward gaze palsy versus partial third on the left side. But the right third is there because efferent is affected. Left third might have been partial. Left sensory fifth nerve versus ascending with the thalamic tract lesion on the right side. Left renal sense, parallel tract on the right side. Okay. These are the localization structure. Pardon? Your voice is breaking, you know.
to differentiate between upward gaze palsy or bilateral superior rectus weakness, did we check the Bell's phenomenon or something like that?
Okay, we'll come to that later on. So, Bell's phenomenon is all absent. Not moving upward. I'm not moving at all the upward. Okay. That's a good point. What you mentioned. Look at Bell's phenomenon as well as vertical VOR.
So right third is partial involvement, no, sir? Right third is partial involved.
What is partial involvement? Correct. Well, let us see the so how to explain the total loss of vision, the left side. If you click. So you have to optic. What are the points against? There's no RAPD, no optic atrophy, and even easily the right optic tract causing probably the intact left nasal speed could not be checked in view of the extreme adducted position. These are the thoughts I had in mind. How to explain all these things? Because since eye is totally adducted, you will not get the able to check the nasal field. So it is suddenly blind, totally blind on the left side. So it could be right optic tract plus partial effect on the left optic tract. Right optic tract, total hemianopia on the left side. That nasal field cannot be checked. And partial effect of the optic tract causing the hemianopia. Is in the bended optic radiation. There is also another possibility. There is incongruous effect of the optic tract conditions kind of a patchy involvement. Again, hard to believe it. Again, you have to postulate left hemianopia. Left nasal field could not be checked. That's the way you have to postulate. So one can postulate least extending from the retrogradiform part of the internal capsule bilaterally extending to the upper brainstem. Okay, whether it is optic tract or the optic radiation. If it is a brainstem lesion, it can extend. You have to indicate more likely optic radiation rather than optic tract. So what do you want? Okay. So 3rd March 20, there are lot of pictures. I'm showing you everything I will show you. Be patient. Some of them may be boring, but still you have to see that. 3rd March 2020. I'll go fast. Normal MRI. This is the membrane pons. This is again hair sequence. This is equated. This is a coronal cut. It's a date March 3rd, 2020. That is 2 years back. This is a contrast film done at that time. Again, no area of enhancement. This is a scientific cut. This is the C sequence. Again, no abnormalities seen in the brainstem. This angio done at that time. Okay, this impression of the report from the radiology. Then the patient was seen in another hospital and repeat MRI was taken in 9/2020. Okay, about 6 months later. This is MRI taken there again, trial sequence, no abnormality. Pons, membrane normal. This is equated. MRI normal. And another MRI was taken on March 2021. That is about again about 6 months later, 4 months later. We evaluated the paracellular region and the brainstem. Again, this is the picture of the paracellular region. There is optic nerve surface normal. This is the membrane. The region concentrated on the membrane and pons, they appear normal. Okay, it's a rare sequence. Then in December 2021, that is seen in another hospital. Again, I think I will skip that thing. Again, this is MRI finding. They found some abnormality that will come to the later on. This is the medulla, pons. This is the flare sequence. Enlarged view of that thing. Surgical cut. This is contrast. The contrast film. And they thought that there's a possibility of a non-compressive optic neuropathy should be considered. That's what they say. Probably they must have got some atrophy of the optic nerve, which I did not think it was there. So they sent the refer to the ophthalmologist. They did OCT. They did a fundoscopy. The fundus is formed. This is in 2001 January. This is in 2021 December.
The pons and medulla was abnormal.
Normal, they're all normal. They did a VEP is also normal. Then he was in another hospital in 2000, this year, 2022. Then again did a meticulous study of the brainstem. Did a contrast study. They found some abnormality here in the paracellular region. I'll come to that in more detail closely. This is the contrast. They noticed some asymmetrical, see on the right side, I'll show the bigger picture later on. Asymmetrical signal changes are noticed along the left anterior cavernous sinus. And this is superior pressure region showing differential hypoenhancement of the hypoenhancement on post-contrast images. That is the initial report. Then subsequently in 6/2/22, that is 1.5 months back, there is another MRI. Again, the brainstem was normal. They did contrast. Now look at the contrast film in the paracellular region. I will zoom it and show you. This is the abnormality they found. They're shown with the arrow. On the right side, there is an area of isointense lesions in the posterior cavernous sinus. Also in the near the optic nerve close to the chiasm. That is on the right side. This is what they find by the arrow, the symmetrical enhancement. Again, it's pointing out this enhancement there. And this is the arrows which are shown on the right side. So the report was like this. Right cavernous sinus appears mildly engorged, ill-defined T1 isointense lesion, the posterior aspect of the right cavernous sinus. It shows intense enhancement on contrast and seen extending anteriorly towards right orbital lines. Right inner arteries flow-voids appear normal. Left cavernous sinus is normal. Likely, right cavernous sinus inflammatory pathology suggests a clinical correlation. So, what do you think about that finding? That finding cannot explain many things. You can't explain the total loss of the left eye. You can't explain the left side position. You cannot explain the longitudinal signs. You can't explain the left spatial sensory loss. Nothing can be explained on the left side. Whatever they found is on the right side.
Could it be functional, the left eye?
Functional means
the vision loss of the left eye, because VP is normal, but
yeah, that's something you have to keep in mind. Maybe so. Yes, got some functional overlay. There is thing to strongly consider that patient. But thing is, the right pupil is dilated and left plantar is upgoing. That's the thing which is, and the adducted position of the left eye. Okay, let us see the investigations done. Then in February they did a field chart, right? So periodic termination, just like we got. Again, another field charting showing that same thing. They didn't be able to say that absent P100 latency, but that is in March 2022. But we did repeatedly, and this is the report. Mr. Karthik on the examination is scheduled on the right side, no PL on the left side. Intraocular pressure is 20, and this examination showed dilate pupil due to Cori, then isotropia, the non-reacting, they said non-reacting, actually it is reacting. Field of visit, right eye superior autoimmunopia, that shows normal appearance of optic macula. So they did NMO spectrum antibody negative, serum electrophoresis is normal, and your ACE level is normal, CSRAC level is also normal. Then the CSF was reported to be normal. And the last MRI done before they came was from this hospital. That is the 16th to this year. Again, we find no abnormality could be found out. In fact, altogether, we went about 7 or 8 MRIs in different places. This is the discharge summary from that hospital. The same story which I have given there. So I saw the patient on March, last week of March. So I was totally confused after what it is. I thought maybe we are definitely dealing with a midbrain lesion extending upward. And probably left eye could be functional element, cannot be told, totally ruled out. But there is something which cannot be explained by functional element. So I repeated the VEP. VEP is normal bilaterally. Previous finding of VEP actually is not correct. It was normal bilaterally. Then we did I wanted to do a tractography because sometimes I've seen brainstem gliomas infiltrating where you won't find any gross abnormality. Years later only they come up to the surface out because they insinuate to the tracks. So I wanted to do the tractography. So I did a 3T machine MRI, concentrating on the midbrain and the upper brainstem. And the DTA was also done, find out any tract involvement. It was all normal. So this is the MRI, deepest MRI done. This is the orbital cut to find out the muscle involvement. Paracellular region normal. So I think skip the report. I said nothing abnormal. And reported by a very good radiologist. Now, what do you do now?
What about spinal MRI? Because its plantar was upgoing and there was a sensory level.
That MRI is done. I think I skipped it because of the step time. I showed the report. I did not show you it is not normal. I think somewhere I skipped that thing.
Sir, what are the EEG findings?
This is the find. See, this whole spine scanning was done. Cervical dorsal lumbar spine normal. EEG did not do.
The neostigmine test was done?
It was done earlier by the other hospital, but I did not do that. Because pupil is dilated, no question of doing neostigmine test. Long track signs are there.
Okay.
So what is your diagnosis now? Totally confusing.
Convergence
For autoimmune.
Pardon? You wait for another 6 months and take a repeat MRI. Already 7 MRIs have been done.
CSF for autoimmune.
CSF was done. Autoimmune, they did I don't know the autoimmune antibody panel. They did that serum electrophoresis, everything was done. That is normal. CSF was also routine basis. So in fact, truly speaking, for 2 days I have been thinking for this case day and night to find out some explanation for this thing.
The only real abnormality is the fixed adduction of the left eye and the large right pupil.
And plantar ongoing.
Left plantar we can ignore, I think, because his
maybe.
spine and everything was normal.
But
We can't give anything for the. We can't give credence to his sensory impairment because it can again may not be abnormal at all.
Yeah, that sensory sensitive examination can be really tricky. But certain things which cannot.
He has can the right pupil be dilated on a congenital? Any congenital disease?
No. He said he developed photophobia, and then went to the doctor. That's what he said. And then
EDC is done in this patient. Nerve conduction study.
Nerve conduction they did was normal. They did earlier. That I did not do. The report is there. I skipped that. It's normal.
Okay.
So can
the right pupillary?
So can we say that the convergent passage?
Convergent pulse will be right. Eyes remaining converged. No, it's not a convergence palsy. So let us see.
Can the right dilated pupil be normal for him?
Eddie's pupil, like.
No, let's see. Let us see analyze the problem. Let us now come to that. So this is thing. Is it functional overlay? Functional overlay is there, but everything functional is it possible? Very unlikely. So let us analyze each finding in this patient. Let's take the total loss of vision of the left eye. Is it functional? Most likely functional because normal light reflex, no RAPD, fundus shows no optic atrophy even after a long period of time. We repeatedly know. Second point, right pupil is dilated and fixed. That is definitely it is there, no doubt about it. So obviously this cannot be functional. Where is the site of lesion? It can be efferent third nerve, which may be preganglionic, that is from the third nerve nucleus up to the ciliary ganglion, or postganglionic, just home side is pupil, or it may be in the muscle, cortical blockade. Now, what will you do to differentiate these things? Which I did.
Dilute pilocarpine test.
Yeah, very good. Dilute pilocarpine for home study, but a strong pilocarpine for third nerve as well as pharmacological blockade. So, pilocarpine test was done. So, dilute pilocarpine test, no constituent of the people. So, that means it is unlikely to be in the ciliary ganglion. Or additional to that, for the innovation supersensitivity. So we did 1% pilocarpine test, again no constriction, rules are preganglionic in third. In fact, we repeated the test with 2% pilocarpine, still no reaction. So what does it tell you? It's got a pharmacological blockade. That means somebody is instilling some form of drug into his right eye, either he or someone else. So I suspected. Then what I do, I asked the patient, he denied installation of any eye drops or ointment in the right eye. So I asked the father who is staying with the boy in the room, search his almirah and bag, everything for in his eye drops and ointment. When he is sleeping and when he is in the bathroom. But this father was very cooperative with me. So he said, no, I couldn't take out any ointment or eye drop. Search his room for any eye drops, which he was, when he was away from the room, he could not find any eye drops, nor any ointment. So that is the second one problem. The third problem, what is causing is adducted position in the left eye. So was it again functional? So you may think that how can one adduct one eye alone? But it's impossible. We cannot adduct one eye alone normally. So very unlikely we can conduct one of the yoke muscle alone. So what will you do? Was it due to the overaction of the left medial rectus? That's the first thing to find out. Due to weakness of the left lateral rectus, which is the most common cause, or due to contracture of the right medial, it is left, left medial rectus.
You can do a traction.
Yeah. So what will you do? with a post-traction test. Now, this is a post-traction test. You could bring back the eye to the midline easily, stop contracture, and beyond that, it is some restriction there. Okay, this is the post-traction test. So this is the report from that ophthalmologist who did it for me. Positive tight middle rectus beyond midline, increasing, which is increasing with the beyond midline, probably due to long-standing use of protein. Unlikely due to left lateral rectus weakness. Naturally, it's unlikely to lateral rectus weakness. If just due to the middle going very smoothly outward. So he is pulling the middle, I mean, keeping the right left eye adducted most of the time. But there's no contraction. So just overaction the middle rectus. No, what is causing is overaction? Due to the contraction of middle rectus, there is unlikely. So I checked the orbital scan once again, did orbital CT, to find out any shortening of the middle rectus or any thinning of the middle rectus. This is the orbital CT. The muscles are normal. Initially thought left middle was thickened, but not there. It is not there. So this is axial. Now this question is, there is no atrophy or hypertrophy of the middle rectus. The next question, was he doing voluntarily? So I couldn't even think that this can ever occur. But then I discussed with my chief professor. He said, skin patients people can adapt one eye alone. So I wanted to prove that it is present when the eyes are closed. I wanted to see whether the eye is remaining open or closed when the eyes, when the eyes are closed. So I did a repeat CT scan in the orbit with eyes open and eyes closed. This is with eyes closed on the right side.
Left is closed, right is open.
But it is still remaining in the adducted position. Again, I couldn't prove my point. And I was wondering how can one person do like that? So what did you do? So I wanted to prove that he's contracting his middle rectus voluntarily. That is my aim. So you may ask, how can one do that? Because I told you before, my professor, I told me some people can do that. So I went back and checked all the MRI fields. MRI ought to remain, but for quite some time with the MRI country. Let us see the MRI or the orbit taken the present condition. See the orbital position. It is normal. It is not at all adducted. In all the MRI something taken before, it was not remaining normal. This is left eye. It is not at all in the adducted position. So his tendency, my feeling is that he is contracting his middle rectus alone.
But did he know that while doing this CT was being done for this eye position?
Yeah, that's a good question. He is a very, very intelligent boy. Very intelligent, super intelligent. He is good for an education. Even the mildest thing which I have in mind, he will read my mind. So that's why I went back and checked the MRI of the one. The orbital CT, only orbit means CT only we can remain for only 1 or 2 minutes, no? But the CT will remain for a long period of time. That is, there's another MRI, previous MRI also I will show you before, show again. I also showing the eye position is normal. So then what I did was I went back again, tried to coax him to abduct his eye as far as possible. I told him
try.
Made him try again. He's able to move it little bit. Initially you are not able to move it at all.
Try to maximum. It's coming now. It's coming now. Come. Verite. What try it?
So he was able to bring it back. The next problem was decreased pain on the left side of the face. Is it genuine or not? The pain extended beyond the supply of the fifth nerve. If you look very carefully, normally it should stop straight short of the vertex and it is not encroached on the occipital region. It should encroach on the angle of the mandible. Here, the ear trailing normal only when it reaches the neck. You must have missed that particular point. And the left corner reflex is normal. Which loss of pain left corner should have been ascending conducting. But affection on the left, whatever you find on the right side is the same as the left side. Again, that does not tally. The next problem is left upgoing plantar. So was it a pseudoplantar? So I had to do the plantar response after diverting his attention. Speaking to him and then did it again, but it is still upgoing. See that? I was talking to him continuously to divert his attention. I told him he's a super individual guy. The next problem, what did he do? Still it is upgoing. So what I did was, see, this is what I did. I trimmed the part, lateral part, and remain the stimulus at that point. It's upgoing. They're all still upgoing. Okay. Then I kept the stimulus in that point, remaining there. See this data. Let's see what I did. I kept it there. It remained upgoing. Normally, a plantar should just come back in the position once the stimulation is stopped. Remain upgoing. See? It keeps it as long as keep it remain upgoing. That's not what should a normal plantar should do. So this is the book which I have written about technical. No response may occur within first few centimeters of stimulation, and continues to remain tonically extended as stimulation continues. In some patients, in particular, that's forgettable. Just after the release of the stroke, the toe then promptly and slowly returns to the neutral position, flowed back into the neutral position. These are the points. This is the point I'll skip. So, what is your final diagnosis now? The many things are functional. Plantar is quite, he is lifting up the plantar. Whatever stimulation you do, continue to put the finger also, it goes upward. The sensory loss in the face is functional. Visual loss is functional. The pupillary dilatation is not functional. For that, we have to find explanation. It's a pharmacological blockade. That is for sure. For pharmacological blockade means he must be instilling symptoms in that, or somebody is instilling that. So this is some kind of a Munchausen syndrome. This is what Sir has thought for me to consider that. He only considered this possibility, which I thought that's most likely possibility here. Expectation disorder is serious mental disorder in which someone deceives others by appearing sick, by purposely getting sick, or by self-injury. So that is the story of this patient.
So what about the right superior hemianopia?
The hemianopia can be functional also. So all sensory system examination can be subjective. Just like decreased pain on the left side of the body, it can be subjective. We can say upper part is not seeing. Objectivity is not there.
This is real Sherlock Holmes, sir.
Yeah, if really, I must have spent about 3 or 4 days behind this patient. And then ultimately, I called the bystanders, and parents were educated. I called my house and I told him each step. There was also one doctor along with that. I made him convinced and draw the diagram, everything. So this just cannot occur, this thing. So ultimately, they agreed for counseling and psychiatric consultation. It will be a really tough thing to correct also. Because he himself is a medical student. He knows all these things, how to fool us. And he's a very, very super intelligent guy. Okay.
Is he from Thrissur?
Pardon?
Is he from Thrissur?
You are right, but don't tell others. No, I don't want.
Sir, have you seen any midriatic pupil without any third nerve paresis, muscle paresis?
Yeah, only
besides any pharmacological, because all I have seen are all pharmacological.
Yeah, there are two, three conditions I have seen. One is pharmacological blockage. Third is home studies people. The other thing is in home study people can occur alone as a part of a post-viral syndrome. And Miller-Fisher syndromes can only affect the people. That I also see. But the extra muscle involvement.
But it should be bilateral. No?
It should be bilateral. Miller-Fisher is bilateral.
Yeah, but Addis people does react after a long time. It's just
Yeah.
totally Midriatic people.
Right, exactly. The dilatate, see that it's fully blown out people that occur seen only in Midriatic people. I mean, pharmacological blockage. Midriatic induced people.
Is the patient asthmatic? Does he have any access to inhalers? Because these inhalers can itself cause this one pharmacological dilatation. All this.
Yeah, what you said is perfectly right, but should be bilateral in that case. It is only to sides. There is some what you said is correct. There is one case report in which there was inhaling that was going and affecting the people producing pharmacological dilatation. You are right.
So how common is Botox given for this convergence of the eyes, sir?
No, that's done by the ophthalmologist. I don't know.
Is it commonly given, sir?
No, I know idea because I'm giving for the first time in this patient. They went to various hospitals and they did.
The squint specialist.
The history of recurrent convergence spasm also is
And lead by Botox.
the history of recurrent convergence spasm also is suggestive of something like a functional.
Yeah, exactly. Looking back, right. So he has been fooling us all along.
But unilateral convergence is a bit more difficult, no, sir?
No, very difficult. Very difficult. Bilateral agreed. So in fact, Rata sir had told me that he has seen something like a person who can do it voluntarily on one night. I never seen one.
So observation of the eyes in the sleep can give a clue, no, sir?
Yeah, but that's what we did. He was in the MRI film. His eyes were straight, and subsequently a coaxing he can bring back the little bit he can bring back to the midline position. He's not at all doing that.
So, what is the difference between this convergent spasm and this near reflex?
Near reflex is a near trial when you write. It can be due to two things. One, due to the accommodation type. That is when you bring due to the light, reflex can produce, bring the light towards the cross cortex. There are two ways it can produce. The light itself, the afference, it can go occipital lobe, frontal lobe, from there come back to the individual vestibular nucleus and produce constriction. That's it due to the accommodation to focus a near object. Other is by the contraction of the afferents from the medial rectus. They go through the proprioceptive input from the medial rectus, go to the mesencephalous nucleus of the get connected with the individual vestibular nucleus and produce different. There are two ways it can produce.
The one is a visual pathway, other is
but it's the afferents from the for the near reflex, for the convergence, for the adductive or the contracting medial rectus muscle.
Okay, sir.
That is why even if you are blind, even if you are blind, you can have a accommodation reflex, a convergence reflex.
Yes.
It's called psycho-optic reflex. Imagine that you are blind. You put your hand in front and imagine a hand is coming towards the nose, people will constrict. You are totally blind. That is by the contraction of the medial rectus. The proprioceptive input from the hand gives command for the medial rectus to contract, and then afferent from the medial rectus goes by posteriorly and contract the pupil. And this by the vision. If you want to see from the distance to near object, the pupil is contracting as a part of the lens modification. So the main function, the ciliary muscle contraction. For that, you have an accommodating reflex. Lens has to be adjusted to focus on a near object. The accommodation part, there is a visual part. That also can produce convergence and pupil constriction.
Sir, ophthalmoplegic migraine, any possibility?
In this patient?
Yes.
No. I think it's a persistent disorder. Many things, so many long drive sense, everything is there.
We have used an optokinetic drum to assess him. Can you
No,
assist the
that-
optokinetic drum?
No, I did not do that because, see, in fact, he is not, in fact, the left eye is remaining erected all the time.
But MRIs are different times showed different.
That's only subsequently, when you try to prove that point, I was looking back the MRI whether he's could bring back the eye normally or not. Nobody suspected functional from the very beginning.
Yes. I had one case who was suspected to be having myasthenia with kind of a unilateral convergent spasm, actually. One young boy.
Yeah, that is possible. Myasthenia muscle disease can possible. Cannot be if it is a spasm or weakness of the contraction. Usually they don't produce overaction of the muscle. Myasthenia will not produce overaction unless it is paralyzed. In myasthenia, in the resting position, it will never be going to overaction. Okay. Unlikely to be a myasthenia. That should occur in myasthenia. Paralysis, yes. Suppose you got a 6th palsy, there is overaction of the muscle can occur. But in myasthenia resting position, there is no question of overaction. Okay, it's already time has passed. So, okay, next week I will bring another case, interesting case.
Thank you, sir.
Thank you. Good night. Good night.
Thank you, sir.
Thank you. Good night.